PhD that has a strong emphasis with reactive attachment disorder. I also run a business called Families Reconnected, and that focuses on parent education and child and adolescent behavior consultations. So with that out of the way, let's go ahead and get started. So attachment is a deep and enduring emotional bond that connects one person to another across time and space. Attachment does not always have to be reciprocal, meaning that one person may have an attachment to another person, but it's not shared. Hang on, my mouse isn't working. There we go. When it comes to what attachment looks like in children, it is characterized by behaviors like seeking an adult they have a bond with when they're upset or scared. Attachment in adults looks towards children looks like responding appropriately to the child's needs. These behaviors appear universal across cultures. So we're going to talk about the attachment theory a little bit. The attachment theory explains how the parent-child relationship emerges and influences subsequent development. John Bowlby is the psychiatrist who created the attachment theory when he was working with children who were emotionally disturbed during the 1930s. He realized that the importance of the child's relationship with their mother for their social, emotional, and cognitive development. Through his research, he saw that children experienced severe distress and anxiety when they were separated from their mothers. A lot of other researchers of the time thought it was just because the mother fed them. So the attachment was solely based on food. However, the kids were still experiencing high levels of anxiety even when they were being fed by another caregiver, proving the other researchers wrong. Bowlby suggested that attachment can be understood with an evolutionary context and that the caregiver provides safety and security for the infant, meaning that attachment is adaptive as it enhances the infant's chance of survival. So the baby is biologically hardwired to attach to those who meet their needs so it can survive. Like I mentioned before, infants and kids have a desire to be close to their parents when they are scared or upset. So there's really two main theories, and psychologists have basically said there are two theories that are believed to be important in forming attachments. The learning or behaviorist theory of attachment suggests that attachment is a set of learned behaviors. The basis for the learning of attachments is the feeding process. So an infant will initially form an attachment to whoever feeds it. They learn to associate the feeder, who's usually the mother, with the comfort of being fed, and through the process of classical conditioning, they come to find contact with the mother comforting. They also find that certain behaviors, like crying or smiling, being desirable responses from others, like attention and comfort, and through the process of operant conditioning, learn to repeat the behaviors to get the things they want. The evolutionary theory of attachment suggests that children come into the world biologically pre-programmed to form attachment with others, because this will help them to survive. The infant produces innate social releaser behaviors, such as crying and smiling, that stimulate innate caregiving responses from adults. The determinant of attachment is not food, but care and responsiveness. So the baby realizes that if I cry, they come feed me. If they come feed me, then I trust them to meet my needs. This theory implies that a child would initially form only one primary attachment, which is usually the mother, and that the attachment figure acted as a secure base for exploring the world. The attachment relationship acts as a foundation for all future social, familial, peer, and romantic relationships. So messing up that first attachment can have pretty severe consequences. This theory also suggests that there is a critical period for developing an attachment. Research differs on exactly what years are the critical period. Some say 0 to 3 years of age, others say 0 to 5 years of age, and some say only the first year of life. Personally, from what I've seen and researched, I believe that the first 3 years of life are the most important when forming attachment. Regardless, the critical period of developing an attachment
But
is the
Adam,
very, very,
5.
is there a question? Okay, never mind. Personally, from what I've seen and researched, I believe that the first 3 years are the most important. Regardless, the critical period of developing an attachment is the very young years of a child's life. If an attachment has not developed during this period, then the child will suffer from irreversible developmental consequences such as reduced intelligence and increased aggression. So there are stages of attachment, and the first one is to 6 weeks, around there. Very young infants are asocial in that many kinds of stimuli, both social and non-social, produce a favorable reaction, such as a smile. Indiscriminate attachments are from around 6 weeks to 7 months. This is when infants indiscriminately enjoy human company, and most babies respond equally to any caregiver. Also, they get upset when an individual ceases to interact with them. From 3 months, infants smile more at familiar faces and can be easily comforted by the regular caregiver. Next, we'll talk about the specific attachment, which is right around 7 to 9 months. Babies give special preference for a single attachment figure, which, like I said before, is usually the mother. The baby looks to particular people for security, comfort, and protection. It shows fear of strangers and unhappiness when separated from a special person. Some babies show stranger fear and separation anxiety much more frequently and intensely than others. Nevertheless, they are seen as evidence that the baby has formed an attachment. This has usually developed by 1 year of age. So the next stage is multiple attachments, and that's 10 months and onward. The baby becomes increasingly independent and forms several attachments. By 18 months, the majority of infants have formed multiple attachments like mothers, fathers, grandparents, siblings, and neighbors, with those who have responded accurately to the baby's signals, not the person they spend more time with. It has been shown that strongly attached infants had mothers who responded quickly to their demands and interacted with their child. Infants who were weakly attached had mothers who failed to interact. The most important attachments is not who feeds and changes the child, but who plays and communicates with him or her. Therefore, responsiveness appears to be the key to attachment. When there is little to no responsiveness, severe consequences happen that lead to significant attachment problems like reactive attachment disorder. So we're going to go over some of the basics of RAD. And I do want to point out that reactive attachment disorder is a huge topic. And so it's a lot of generalizing. And if there's something that I'm not going over, it's just because I have to cram it in. You could honestly talk about RAD for like 3 days straight. But so I'm going to generalize and just kind of go over topics so that way we save some time. So the basics of RAD. RAD was first documented by the American Psychiatric Association in 1987, and it was placed in the 3rd edition of the DSM. And it essentially is a serious disorder that develops in babies or young children that do not create healthy attachments with a caregiver if their basic needs of affection, comfort, and nurturing are not met. The DSM-5, so 2 editions later, classifies reactive attachment disorder as a trauma condition of early childhood. Like we discussed earlier, it has to happen pretty early on, and it's caused by social neglect and maltreatment. Children who are affected by this have difficulty forming emotional attachments to others. They also show a decreased ability to experience positive emotions. In general, they cannot and will not seek or accept physical or emotional closeness and may react violently when held, cuddled, or comforted. You know, behaviorally, these children are pretty unpredictable, difficult to control, and extremely difficult to discipline. Their moods fluctuate erratically. That's why a lot of the time I've seen kids who actually have RAD, but they're actually diagnosed with DMDD, which that is disruptive mood dysregulation disorder. And that is a mental disorder in children and adolescents characterized by a persistently irritable or angry mood and frequent temper outbursts that don't make sense to the situation and are significantly more severe than the typical reaction of same aged peers. So, RAD is misdiagnosed frequently from both directions. It is also important to mention that these kids are constantly living in the flight, fight, or freeze mode. This makes them feel like they need to try to control their environment and make their own decisions regardless of what else is going on or who wants to take charge. Expectedly, a lot of these problems go to school with them too, and these challenges inhibit them from really understanding and grasping their core subjects in social situations, which leads to rejection from teachers and their peers to the point in which they don't even like going to school and they don't like being at home either. So you can imagine how difficult it is, not only for the adults in the situation, not only for the peers in the situation, but for the child with RAD too. All of these challenges come together, and as they form through their childhood, they get up to adolescence and later into adulthood. All of these socially neglected children are more likely than their neurotypical peers to engage in high risk sexual behavior, substance abuse, and have a lot of involvement with the legal system and experience incarceration. So, we're going to talk about the rise of RAD next. And reactive attachment disorder is a rapidly developing issue in the world of psychology and social work. It's mostly associated with foster children that have been taken into state's custody for issues such as neglect, physical, sexual, and or emotional abuse and other maltreatment, which makes complete sense considering the biggest reason that RAD happens is because of the child not receiving their basic needs being met at such a young age. And foster children come into care more often than not because of some form of neglect or abuse. In 2017, there was over 430,000 children in the United States foster care system. And of those, it's estimated that between 18% and 39% are suffering from RAD. I don't know about you guys, but when I first read that statistic a few years back, it blew my mind. I knew that attachment disorders were frequent when it comes to kids in care, but I didn't realize how much was truly on that part of the spectrum as far as reactive attachment disorder. I see the world of attachments on a spectrum. You know, on one end, you have that reactive attachment disorder, and on the other end, it's almost that you are too trusting. And I feel like each one of us falls somewhere in the middle. Well, hopefully, most of us fall directly in the middle, where we're not too willing to be open and trust everybody, but also not completely have no trust in anybody, that you're unwilling to form attachments and have good relationships with other people. Anyway, children who have been diagnosed with RAD typically develop other disorders too, like PTSD, developmental trauma disorder, behavioral health disorders, social disorders, and substance abuse disorders. This comes from the abuse and neglect they experienced in order to form reactive attachment disorder. So there are two types of RAD. Well, in the past, it's been said that there are two types of RAD, which is inhibited and disinhibited. Now, some professionals are suggesting that one of those is RAD and that the other is a completely new disorder, which is disinhibited social engagement disorder. However, I feel that this is something that could change back in the future to just having two types of RAD again and go back and forth forever. So I will explain it both ways. The two types of RAD, inhibited and disinhibited, are in how the caregivers mistreat them when they're young in those critical developmental stages. In the inhibited type of RAD, the caregiver does not offer the comfort or emotional support when the child needs. This type identifies children who have no preferred caregiver, rarely seek comfort in times of stress, show a minimum of positive affection, and experience difficulties in the regulation of their emotions. The behaviors that result from this form of RAD are more solitary, evasion of soothing gestures, self-soothing activities. They have a lot of caution and have a lot of aggression in some social circumstances. For the disinhibited version of RAD, the caregivers are not reactive toward the child's needs, but they can eventually be coerced into responding with affection. This results in manners such as inappropriate familiarity and comfort seeking with unfamiliar persons, embellishment of needs for help, and enduring uneasy appearance. The disinhibited subtype identifies children that may only engage in contact with relatively strange adults and rarely socially discriminate between the caregiver and unfamiliar adults. The current DSM-5 separates RAD into the two different disorders instead of types. Inhibited behaviors are still considered symptoms of the reactive attachment disorder, but disinhibited behaviors are now described as symptoms of disinhibited social engagement disorder. There is only one study out there that suggests that RAD is two disorders, but there's little evidence available to support the division of the inhibited and disinhibited types of attachment disorders. So like I said, more than likely, it will go back to just being those two types, but we'll see. So the causes of RAD. The origin of reactive attachment disorder is always trauma, specifically the severe emotional neglect commonly found in institutional settings such as overcrowded orphanages, foster care, or in homes with mentally or physically ill parents. Over time, infants who do not develop a predictable, nurturing bond with a trusted caregiver do not receive adequate emotional interaction and mental stimulation, which halt their attempts to engage others and turn inward, ceasing to seek comfort when hurt, avoiding physical and emotional closeness, and eventually pretty much become emotionally numb. Basically, they try to establish a bond over and over again as a baby, but if there is not a caregiver to reciprocate, then they give up. This absence of adequate nurturing results in poor language acquisition, impaired cognitive development, and contributes to behavioral dysfunction. So RAD and other attachment disorders occur when a child has been unable to consistently connect with a parent or primary caregiver. If a young child repeatedly feels abandoned, isolated, powerless, or uncared for, whatever the reason, they will learn that they can't depend on others and that the world is a dangerous and frightening place. Sometimes the circumstances that cause attachment problems are unavoidable, but the child is too young to understand what has happened and why. To a young child, it just feels like no one cares. They lose trust in others, and the world becomes an unsafe place. Something interesting to add is that research suggests that rates among siblings raised in the same house there's a higher chance, like 67 to 75% chance that the siblings will have RAD as well, which is extremely high, but it also makes sense because they're experiencing more than likely the same abuse and neglect. So, like I said, more than likely, if one sibling has it, then the others will too. Now, that's not always the case, but most of the time. Neither gender nor ethnicity alone appear to be risk factors for developing the disorder. However, African American and multiracial children experience higher rates of child maltreatment than do their non-minority counterparts, which likely translates to a higher incidence of reactive attachment disorder in minority populations. So this is a pretty telling picture, and I always include this when I talk about reactive attachment disorder, because in this picture, this is the brain of a 3-year-old child. On the left is a neurotypical, which means basically normal, if there's such a thing, brain of a 3-year-old. The one on the right is the brain of a neglected child that has RAD. So you can physically see the differences. There are pieces of the brain that are supposed to be connected that are literally separated. The extreme form of neglect that causes RAD can permanently change the way that a brain matures, forms, is structured, and functions, which can cause significant difficulty in regulating cognition, emotion, and behavior. When a developing brain that should be a positive environment for increasing neural activity and creating synaptic connections has a constant stimulation of neuroendocrine system and inflammatory pathways, then the neural connections fail and the neurons die. Basically, constantly being neglected makes parts of the brain die. So the prefrontal cortex, which is the front of your brain that controls personality, expression, decision-making, impulse control, and social behavior, is not fully developed in children anyway, but in children with RAD, it is even less developed. So when a child has RAD, and people get extremely frustrated with the behaviors of RAD, which we're going to get to in the next couple slides, but it's not the kids' fault. Their brain is literally wired in a different way than ours. They're part of the brain, that prefrontal cortex, that helps make proper decisions, which is not fully formed in children as it is, but when it comes to a child who has reactive attachment disorder, it's completely wired differently, and they don't have the ability to make those proper decisions. They also don't have the ability to control their impulses or to understand social behaviors in a way that makes them feel safe. Everything that they see that we believe would be safe and trusting and create the ability to form a wonderful attachment with another human being is their absolute worst nightmare. Everything we deem is safe, they are afraid of. We want comfort and we seek it from others. They believe that there's no one on this planet that can truly comfort them in the way that they need because everyone else has failed them before. So I know, I've been there. that when these behaviors are going on and you're just losing your absolute mind over it because, how can you keep doing this? I can't believe that this kid keeps doing this to us. We made the worst decision letting them come into our home. I get it, but it's not their fault. If they truly had a proper working brain, they wouldn't want this, but that's not the cards that they were dealt. Unfortunately, they had to experience extreme abuse and neglect that literally made parts of their brain neurons in their brain die. Their brain is rewired in a way that prevents them from leading a life full of love and belonging and trust in relationships with adults and peers. I know it's hard, but I always really want to emphasize this part, that they didn't choose this life. They didn't choose to be abused and neglected. They didn't choose for pieces of their brain to be different than everyone else. And in the most difficult and chaotic moments when dealing with kids who have RAD, kind of keep in mind that deep down, these kids are hurting. They don't even know that they are really hurting and suffering. And it's our job as people who are willing to foster or adopt or work with these kids to step up. It's our job to step up and realize that their behaviors are a form of communication and they don't know how to do it differently. It's also our job to keep trying to help them, even if it's hard. So, like I said, I'm getting off my soapbox a little bit. We're going to talk about those behavior signs and symptoms. This is not an all-inclusive list, and maybe some of these you've never seen in your child who has RAD before. But like I said, I'm just going to quickly go over behaviors, signs, and symptoms for babies and younger and older kids. Many of you have experienced these behaviors firsthand, so I am preaching to the choir a bit, but maybe you might see something you've never experienced before. So, signs for babies would be that they avoid eye contact, they don't smile, they don't reach out to be picked up, they reject your efforts to calm, soothe, or connect with them. They don't seem to notice or even care when you leave them alone. They cry inconsolably, like there's nothing that you can do to get them to stop crying. They don't coo or make sounds like babies do, and they don't really follow you with their eyes. They're also not interested in playing interactive games or playing with toys, and they spend a lot of time rocking or comforting themselves. It's important to note here that the early symptoms of attachment disorders are very similar to the early symptoms of other issues such as ADHD and autism. If you spot any of these warning signs, make an appointment with your pediatrician for a professional diagnosis of the problem. This is where you strongly advocate for them to be referred to the proper professionals to help make proper diagnoses. So now we'll go over in young children. They can have an aversion to touch and physical affection. Children with RAD often flinch, laugh, or even say ouch when they're touched, and not in like a painful way being touched, but just even lightly being touched. So rather than producing positive feelings, touch and affection are perceived as a threat. They also have control issues. Most children with reactive attachment disorder go to great lengths to remain in control and avoid feeling helpless. They're often disobedient, defiant, and argumentative. Anger problems and aggression are very common as well. Anger may be expressed directly in tantrums or acting out, or through manipulative, passive-aggressive behavior. Children with RAD may hide their anger in socially acceptable actions, like giving a high five that hurts or hugging somebody way too hard. Difficulty showing genuine care and affection. For example, children with reactive attachment disorder may act inappropriately affectionate with strangers while displaying little or no affection toward their parents. An underdeveloped conscience. Children with reactive attachment disorder may act like they don't have a conscience at all. They don't know the difference between right or wrong, and they fail to show guilt, regret, or remorse after behaving badly. So some of the behaviors, signs, or symptoms of older kids. They're superficially engaging and charming. So like when you first meet them, they can be extremely charming and you could think that they're the most polite child that you've ever met. They lack eye contact. They won't make eye contact, especially on parents' terms. So when you're face to face with them, or even when you're, dealing with discipline, they will not look you in the eye, especially if it's on your terms. Now, they may look you in the eye when they want something or they want to be manipulative, but they really don't like that contact, because when you're creating eye contact with somebody, it gives the ability for a bond or attachment to form. So indiscriminately affectionate with strangers, that was just like with the younger kids too. And then not affectionate on parents' terms. This kind of is similar to the eye contact. They may be affectionate when they want something, or they may be affectionate to other people, other parents, if they're trying to divide them. But it definitely won't happen on your terms. They're destructive to self, others, and objects or things. I have seen kids with RAD literally pull their own teeth out and not have any emotional reaction to it. I've also heard stories of kids who would find like a fish hook and they would put it through their skin, obviously cutting and other stuff like that. They just don't have that emotional response for it. They also don't have that bond with others, which when they hurt them, they don't feel bad for it. They don't have the conscience for it, but they also don't have that connection with somebody, so they truly don't care if they get hurt. And then they destroy objects or other things because, like I said, they don't really care, and sometimes they just destroy objects and other things to push your buttons, and we'll talk about that later. Cruelty to animals. This one is actually a personal thing. We have dogs, and when we had a child with RAD in our home, the dogs like to sleep in the bedrooms with the kids because they're just the sweetest things. But we woke up one morning and the top of the dog's paw had been completely, like the fur and skin had been peeled off, which is just extremely gruesome. And more often than not, parents who have children with RAD in their home, and like if they're going to adopt them and they're going to be there for a while, they usually have to get rid of their pets out of fear that they're going to do something to them. I've also heard of a little girl who they lived out on a farm, and whenever they had farm cats come by their house, she would literally strangle them with her bare hands and show them to her parents and not feel bad for them. She, in fact, enjoyed the distress that it caused the parents. Next one is lying about the obvious. You can show up wearing a purple shirt and they will look at you right, and say, "Oh, I like your green shirt." They don't want to give you the control, and They don't want, so when you say, no, I'm wearing a purple shirt, it turns into a power struggle. And that's not something you want to do with a child who has RAD, because they want to try and control everything, and they'll do whatever it takes to win that power struggle. So next is stealing. I mean, stealing can come from various different angles. There could be so many different reasons for it, like hoarding of food and stuff like that. That's a couple down, but stealing can come from a bunch of different reasons. No impulse control. We talked about that. That prefrontal cortex, it's not developed. So they don't have the ability to control those impulses. More often than not, you can ask a child who has RAD, why did you do such and such? And they will say, I don't know. And they wouldn't even be lying about it. They genuinely might not know. The lack of conscious, so they don't know the difference between right or wrong. Once again, their brain's just not developed in the right way to be able to tell the difference. Abnormal eating patterns. So when you sit around a table with your family at dinner, like with our family, we have a family of 7. We sit together at breakfast, lunch, and dinner, and that's some of our best conversations. We talk about everything. We talk about school, we talk about feelings and all this stuff. Well, what is that? That's family bonding. And so kids with RAD want to avoid any situation that could make an attachment form. So they may steal and hoard food in their room so they can eat at night, because they will want to survive. They don't want to starve. So they will eat at night or other times without you knowing, so that when there is a family dinner, they can say, well, I'm full, because they just don't want to bond with anybody in the family. So next is poor peer relationships. Children who have RAD tend to be able to manipulate adults, and obviously really young children. But it's interesting, peers their same age, it's like they can sense it. And kids with RAD have difficulty trying to control them. And it's just very interesting to watch them interact with same age peers. The next one is preoccupation with fire, blood and gore, and bodily functions. I don't see the fire part a lot. I've seen it a couple times, but they will just like to set things on fire because they can control that destruction. The blood and the gore, they don't have the same, like if we see a lot of blood and gore, it upsets us because we have that connection. We understand that probably hurts. They don't have that connection with other people, so it doesn't bother them as much. And bodily functions, it's all about control. I know of teenagers who have reactive attachment disorder that have to wear diapers or spread all of their bodily functions on walls, or even will make themselves vomit just so they can play with it. To us, it's disgusting. To them, it's just all about control. Another thing is persistent nonsense questions. So a lot of the time, they will ask you about anything and everything that really doesn't matter. Okay, we're going to talk about the weather. We're going to talk about that dog walking down the street. Stuff like that. That way, they can't have good conversations with you that may lead to bonding and attachment. So, despite the fact that they have all those questions, they're avoiding bonding and attachment. They have a nonstop demanding of attention. And more often than not, they have to be monitored at all times. That's why it's difficult if you are a single parent and you work and everything else. It's very difficult for you to keep an eye on them at all times, which is 100% necessary. So that way they don't hurt themselves, others, or destroy various things. Next one is triangulation of adults. So when you have, for example, like in our home, I have my husband and myself, we make all of the rules, We have expectations. A child with RAD, which we've experienced, she would do whatever it took to play both sides. So my husband would go to work, he's a teacher, and I would stay home. And all day long, she would present with just horrendous behaviors. But the second my husband would come home, she would instantly become charming and innocent, and I would talk to my husband about the behaviors, and he would be like, "Really? That happened?" Now, we have a good enough relationship that he realized that she was manipulating him, but I can see how in other relationships that it would create a wedge, and that's what they want. That's what kids with RAD want, because if they break down the structure of a home, then the parents no longer have control. They now have control and they can manipulate you. So next is false allegations of abuse. This one is tricky because in order for them to have RAD, they had to experience abuse and neglect. But because they lie, it's difficult to determine what's true and what's not. And this becomes a huge part of some cases. And there have been times that there was this one instance, a little girl was saying that her uncle was sexually abusing her. Well, they took him to court for it. He went to jail and then later found out that none of it was true. So it makes it very difficult especially when dealing with abuse allegations and stuff like that. They can also, they don't want to form an attachment with you. And so if it's a foster child that's in your home, they may, especially if they're older, say that you did stuff to them. You hit them or you neglected them. You left them in their room for hours upon end. They do this in hopes that one, you'll either give up and disrupt, or that DCF or whichever agency you're through will come take them and move them to a different foster home. Because if they're bouncing from home to home to home, it is less likely that they're going to form that bond and attachment. The last one I'm going to talk about is creating chaos. All they have ever known their whole life is chaos. And so they create that because that's what makes them feel comfortable. And that's how they avoid, making attachments. Does anybody want to kind of share some stories of behaviors they've seen in their kids or kids that they've worked with? Go ahead and put it in the chat because I think that would be pretty interesting for people to share. I'll give you all some time to do that. Nobody has any stories to share? Don't have experiences with it? I tell you what, I'll move on. Oh, wait, never mind. Thank you for sharing. I imagine that's very difficult. And it's very difficult to deal with all of the behaviors, and then they go up to people from church and other stuff like that, and they're super friendly with them. It can become very disheartening very, very quickly. Once again, thank you so much for sharing. So if you have more to add, feel free to add. I'll try to check the chat box when I can. Let's see if this, there we go. So I'll kind of talk about the diagnoses of RAD. This is kind of a boring part, but I think it's kind of necessary. It's something that y'all can look up in the future too. I'll quickly read what the DSM-5 says in order to diagnose RAD. I think it's important so that way, because I know a lot of people say, well, the kid in my home has reactive attachment disorder, but they don't have a professional who diagnosed it, and they don't truly understand what it takes to diagnose it. So like I said, for some, this is going to be extremely boring, but for others, it may be interesting. The DSM-5 gives the following criteria for reactive attachment disorder: a consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers, manifested by both of the following. The child rarely or minimally seeks comfort when distressed. The child rarely or minimally responds to comfort when distressed. A persistent social or emotional disturbance characterized by at least two of the following: minimal social and emotional responsiveness to others, limited positive affect, or episodes of unexplained irritability, sadness, or fearfulness that are evident even during non-threatening interactions with the adult caregivers. The child has experienced a pattern of extremes of insufficient care as evidenced by at least one of the following: social neglect or deprivation in the form of persistent lack of having basic emotional needs for comfort, stimulation, and affection met by caring adults. Repeated changing of primary caregivers that limit opportunities to form stable attachments, like frequent changes in foster care homes. Rearing in unusual settings that severely limit opportunities to form selective attachments, like institutions. So when I say institutions, I mean like orphanages with high child to caregiver ratios. I mean, it doesn't just have to be orphanages. It could be like residential treatment facilities or other stuff like that. This kind of goes into the criteria. C is presumed to be responsible for the disturbed behavior in criterion A. The criteria are not met for autism spectrum disorder. We'll get into that in just a second. Why not? The disturbance is evident before age 5 years. The child has a developmental age of at least 9 months. These diagnostic criteria provide an outline of symptoms. However, providers must also recognize the global impact on cognition, behavior, and effective functioning. RAD increases the risk of anxiety, depression, hyperactivity, and reduces frustration tolerance. Children who have this are likely to be highly reactive, even in non-threatening situations. This next part is the way that you can definitely advocate for your child. So this is about getting the child evaluated for assessments. Clinicians should have, so that's like your doctors and stuff like that, should have a low threshold for referring children with a known history of adoption, abuse, foster, or institutional care to a child psychologist or psychiatrist for a comprehensive biopsychosocial assessment detailing the child's history, description of the symptoms over time, and direct observation of the parent-child interaction. Attachment behaviors and signs of secure attachment, like comfort seeking, good eye contact, child-initiated interactions, should be assessed every time they visit them. Clinicians should maintain a low threshold for referral to a developmental specialist and, like I said, a psychiatrist or a child psychologist. So something that's interesting that I don't think a lot of people realize is that there are 3 types of disorders that need to be ruled out before a diagnosis of RAD can happen, because literally they cannot coincide with RAD. According to the DSM-5, the following differential diagnoses should be ruled out before a diagnosis of reactive attachment disorder. That would be the autism spectrum disorders. Reason being, children on the autism spectrum often exhibit many of the same features as those with reactive attachment disorder. However, there's a restricted range of interest, sensory processing difficulties, and rigid adherence to rituals or routines that are specific to autism spectrum disorder. And another thing to note on that is typically children with autism have difficulty with social situations, whereas kids with RAD have the ability to manipulate social situations and adults. So the next one is the intellectual impairment. Because for a diagnosis of RAD to be made, the child must have attained a developmental age of at least 9 months, and another medical or mental health disorder must not cause social impairments. Impairments in social relatedness equal with developmental age should be viewed as an overall feature of the developmental delay and not solely a response to severe neglect. Next one is depressive disorders. Symptoms of depression may mirror many of the withdrawal symptoms of RAD. However, children suffering from depression maintain the ability to attach and to seek and receive comfort from preferred caregivers. That was a mouthful, but I think it is important. And like I said, you can always go up later and look it up, the DSM-5, what it takes to be diagnosed with RAD. So now we will get into the treatments and interventions. I really want to point out that usually treatment is a combination of multiples of these, and there's no one-size-fits-all solution. Some of these work for kids, some of them don't. You really have to work with the professionals to decide what's working and what's not. And this is not an all-inclusive list. There are other stuff. That's a question. A bonding assessment, so there's a question. So how would a bonding assessment work with a child diagnosed with RAD? It depends on who they're doing the bonding assessment with. There's a lot of other stuff that goes in to bonding assessments. Yes, you could do a bonding assessment. It doesn't mean it would present with results that explain a lot. So it really depends if you're doing it with somebody they've been with for a long time, if they're doing it with biological parents. It's very dependent on the child. And unfortunately, that's the way with a lot of this stuff. It is so child specific because the way one kid presents with RAD versus another, it's very individualized. That's a wonderful question though, thank you. So treatments of RAD requires multi-pronged approach, incorporating parent education and trauma-focused therapy. Parent education focuses on developing positive, non-punitive behavior management strategies, ways of responding to nonverbal communication, which is common, anticipation and coping strategies for when triggers arise, and parent-child psychotherapy, so they can facilitate bonding and healthy attachment. Empathy and compassion are key elements to building trust. Developing a nurturing parent-child relationship is the cornerstone to overcoming the damage caused by severe neglect and abuse. So, individualized therapy treatment. The treatment for RAD centers on the achievement of an appropriate, stable, and nurturing environment that promotes the creation of healthy attachment with caregivers. With that in mind, it must be declared that individualized treatment therapies are limited with regard to RAD because of the need for a family to attach to. However, there are other interventions like psychotherapy, eye movement desensitization and reprocessing, and dialectical behavior therapy can be utilized. So, and I'm going to sum this up a little bit just so that way we definitely have time to go over the other stuff. But when it comes to individualized therapy for children or adolescents with RAD, the focus is on the psychotherapy that emphasizes patterns and rules of implicit memory to help the child to reveal and reflect on them more fully. Doing this creates new patterns of relationships, and it would be illuminated, repetitive, and cultured, so new learned habits may be ingrained in that memory system. When doing that, the psychotherapist, turns on those past events that they had with the abuse and neglect and uses them to promote the self-worth of the individual that they're working with. Play therapy is huge and has been used in conjunction with psychotherapy and produced higher amounts of improvement in children with RAD. Psychotherapy on its own is pretty ineffective against RAD, so the use of other interventions in conjunction with psychotherapy is pretty important to the treatment of the disorder. EMDR was created with the intention of being a treatment for trauma-induced and anxiety grievances. The theory behind EMDR is that it desensitizes negative cognitions and creates positive processes or thoughts into the brain using planned, rapid, or rhythmic eye movement. The eye movement is created by the professional, moving their finger quickly from side to side and having the individual RAD follow the finger with their eyes while maintaining an image of the anxiety-provoking situation and internally repeating that associated irrational cognition or negative self-statements. Basically, it suggests that the alternating left and right eye movements, hand tapping, or other sounds helps children with RAD, and it's the action that prompts the information processing system to activate. When that activates, it seems to have an impact on the way cognition of the traumatic event is managed. This method has proved to be pretty effective in RAD cases, along with other disorders like PTSD. So the next one, dialectic behavior therapy, typically is used in the treatment of borderline personality disorder. It utilizes interventions such as exposure and response prevention, skills training, reinforcement, cognitive restructuring, therapist reciprocal vulnerability, irreverence, targeting, mindfulness of a set of skills, dialectical focus, emotional regulation, and opposite action skills, distress tolerance skills. Basically, it goes into a whole bunch of stuff. Through the use of this intervention, various things happen that lead to healing in the individual, such as learning new responses, emotional regulation, and reducing literal beliefs and rules and attention control. Like I said, that's used a lot in the treatment of borderline personality disorder, but they've seen a little bit of success when it comes to RAD and other attachment disorders. So family intervention theories or treatments and interventions. Family therapy interventions are typically the ones used in the treatment of reactive attachment disorder. This is because part of the treatment involves attaching with a caregiver, and so a caregiver is needed. The family that participates in the therapy does not have to be the child's biological one, because children with RAD usually obtained the disorder through abuse and neglect from their biological family and are in the foster care system. The foster or adoptive family can participate in the family therapy. It's important to note that you could literally have the biological family, the foster family, and if it's in a different adoptive family, they can all participate, because at the end of the day, the more people you can get the child to bond with through all these interventions, the better. So the first one I'll go over is attachment-based therapy. Attachment-based family therapy is essentially used in ways to improve the relationship between the parent and child. The way the treatment works is that it evolves by the completion of tasks that methodically fix the attachment problems that have broken the trust between the parent and child, which damage the bond between them. Like I said, that seems like it's more biologically, like with their biological parents, but you have to understand that they feel like the trust has been broken with every adult. So you can still work with that as a foster and adoptive parent. This is done through the therapist focusing on certain aspects like reframing the relationship, primary emotions, and unmet attachment needs, and facilitating corrective attachment episodes. The next one is TBRI, which I'm sure many of you have heard of. I'll briefly go over that. It was found by multiple professionals that treating complex trauma, like that experienced by foster children who have come from extremely abusive and neglectful homes, require an intervention strategy that includes like these three main pillars. These pillars are A, development of safety, B, promotion of healing relationships, and C, teaching of self-management and coping skills. These go right in line with the principles of TBRI, which are 1, empowerment, which is the attention to physical needs, 2, connection, attention to attachment needs, and 3, correction, attention to behavioral needs. Creating a safe and structured environment that meets sensory and nutritional needs falls under that empowerment principle. To fulfill the connection principle, observational awareness must be held along with promoting an environment that teaches the skills of attachment through playful engagement. Proactive and responsive behavior strategies are critical to satisfy the criteria of the correction principle. Utilizing the methods taught through TBRI looks like the acronym IDEAL. I, respond immediately to the behavior. D, respond directly to the child through eye contact, giving them undivided attention and bringing them nearer to you physically for teaching and guidance. E, respond in an efficient and measured manner. A, the response is action-based. And L, level the response at the behavior, not at the child. I know that there's a lot of opportunities to get TBRI training through Child Ally and various other, Facebook groups. They share a whole bunch of stuff on that one. And that I think is a great one for, parents who have children with RAD to go to. Next one I'll talk about is trauma-focused cognitive behavioral therapy. This type of behavioral therapy is a family therapy intervention that is used as a treatment for people who have experienced or children who have experienced trauma. The most important part of this type of therapy is that the caregivers of the child, the non-offending parents, so this is not those biological parents or biological grandparents, whoever committed the abuse, this is not them, are involved in the entire process of the therapy. And this has proven as to how this type of therapy is so successful in helping children who have undergone trauma. The objectives of this therapy are to address and reorganize the individual child's area of trauma impact, such as affective, behavioral, biological, cognitive, and social. At first, parents and children are separated for their own individual sessions that gives them the opportunity to air out any particular thoughts they have on the trauma experience without offending the other party. So this is perfect because the parents can have a session discussing the child without fear that they're going to hurt the child's feelings or offend the child in a way that makes behaviors even worse at home. And this gives the child an opportunity to share with the therapist on what they feel about their home environment and stuff like that. It also gives the therapist an opportunity to see the child one-on-one, just in general, to see their behaviors and how they speak with others and stuff like that. But eventually, after they do their individualized sessions, they come together to utilize what they've learned in their individual sessions. And that's where the therapist can connect them and really start the bonding process to form an attachment. So, after all that, the best treatment for a child with RAD is usually a combination of therapies. And if over time it doesn't seem to help, then another combination will be implemented. More often than not, the first thing you try, it's not going to work. The second thing you try, it's not going to work. You have to just keep going as much as possible until you find a solution that works for that child. It's basically a trial and error sort of situation because all children with RAD are different with varying needs. So keep that in mind. It is common for individuals with RAD to respond to treatments for a while and then become unresponsive, needing additional support. It just depends on the child. There are so many different ways that they can interact with it. So now we're going to talk about some tools and techniques. I'm going to mention these are generalized. So I can't cover every single tool and technique that would work for every single behavioral problem that you have. Okay, so this is really generalized. But parenting a child with insecure attachment or an attachment disorder can be exhausting, frustrating, and emotionally trying. It's hard to put your best parenting foot forward without the reassurance of a loving connection with your child. So basically, it's hard to parent them when it feels like you're getting nothing in return. Sometimes you probably wonder if your efforts are worth it at all. With time, like a lot of time, and patience, like a lot of patience, and intense effort, attachment disorders can be repaired. However, this takes years and years. There is absolutely no quick fix, and the best thing for an attachment disorder is prevention. And I know that's difficult because when these kids come into care, it's already usually too late and that attachment disorder is there. But if over time they introduce, different parent education, which, includes educating parents on how to properly care for their children to begin with, that would help a lot. However, once an attachment disorder is present, there are some interventions that can start the repair process and make your life easier. You're going to notice, like I said, I'm not solving any specific problems because each one of your children has different behavioral needs. At the end of this presentation, I will list my contact information. If you really want specialized tools and techniques to use on your specific child, please contact me because you'll have to explain a lot of the situation in order for me to decide what interventions may work for them. So, back to the tools and techniques. Have realistic expectations. Helping your child may be a long road. Like I said, years and years and years. Focus on making small steps forward and celebrate every sign of success that you have. Also, you need to stay patient. This process is definitely not going to be as rapid as you like, and you can expect a lot of bumps along the way. But by remaining patient and focusing on those small improvements, you can create an atmosphere of safety for your child. And that's really important for starting to repair their bonding. You need to remember to take care of yourself. I preach self-care so much more than almost anything. You need to reduce other demands on your time, make time for yourself, and manage stress. Rest, good nutrition, and parenting breaks help you relax and recharge your batteries so you can give your attention to your child. This looks different for different people. Sometimes, you can have respite, you can have family come watch the children so that way you can go away for a parents' weekend. Or, and I know this sounds crazy or dumb or whatever, but have a hobby that you do. Wake up earlier than your kids so that way you have that time to yourself. Things like that, because if you don't take care of yourself, there is absolutely no way you can take care of your kids in a way that's really going to help them move forward with their bonding and attachment. So the next one, find support. Rely on those friends, family, community resources, and respite care if you have them available. And you really need to try to ask for help before you really need it to avoid getting stressed to your breaking point. You may also want to consider joining a support group for parents. Facebook, as crazy as it sounds, can be a pretty valuable resource because there are a multitude of support groups on there. And there's so many people from different backgrounds who have had children in their home with RAD, or there's social workers on there who can maybe recommend therapists or child psychologists. It's really important to kind of build a village around you to support you because you definitely need it. You can't do this all by yourself. Next, really stay positive and hopeful. Be sensitive to the fact that children pick up on these feelings. If they sense that you're discouraged, it will be discouraging to them. There are going to be so many times that you want to give up. Raising a child with RAD is an emotional roller coaster. Having foster children in general is an emotional roller coaster, but when you're having to manage the behaviors of a kid with RAD, it makes it seem like the highs and lows are so much worse. This is when, like you're feeling like you're drowning, you need to turn to that support for reassurance. Make your home a safe base for them. Even though there are going to be times that you want to disrupt, or you want to argue with them, or you want to fight back, or over discipline your child, realize that doing so will make you go all the way back to square one, and that is not a place you want to be. Save yourself time and energy by making them realize you will always be there for them, no matter what they do, no matter how bad the behavior is. They will test you as far as you can be tested. But if you give into the power struggle and let them push you past that breaking point, then they know how to manipulate you. And that is not something that you really want to happen, because then things become a game and it's all a manipulation game. And like I said, that's not what you want. So the next one is set limits and boundaries. Consistent, loving boundaries make the world seem more predictable and less scary to children. In general, children who don't have RAD need more predictable environments, but definitely children who have attachment issues. It's important that they understand what behavior is expected of them, what is and is not acceptable, and the consequences if they disregard your rules. This also teaches them that they have more control over what happens to them than they think. You may have to say your expectations 400 times in a day, but eventually they will realize that you are firm in your expectations, what is acceptable, and the consequences of their actions. My big advice on this one is to use the same exact wording each time you describe your expectations and consequences. Because really, the only way to retrain the brain is through consistency and repetition. And if you're saying your expectations the same way over time, eventually you become that little voice in their head. And if that starts to happen, they start to be able to maybe not decide what's right versus wrong, but they understand if I make this choice, which people consider good consequences happen. But if I make this bad choice and I don't follow the rules, then I know that bad consequences happen. So it makes them feel like they're more in control because they have those choices. They know if I go this way, I will be able to not be in trouble, and I'm given more positive interactions and stuff like that. Whereas if I go the other way, discipline comes into play. So next, it's important to take charge, okay, because you're the boss, but remain calm when your child is upset or misbehaving. Remember that bad behavior means that your child doesn't know how to handle what they're feeling and needs your help. By staying calm, you show your child that the feeling is manageable. Also, It prevents them from believing that if they push your buttons enough, you will get frustrated and blow up on them or even disrupt on them, allowing them to not have to attach with you. That gives them control, and that's not something you want because, like I said, they're manipulating you, and then it starts a game, and that's really not a way to be in your own home. So if they are being purposely defiant, follow through with the pre-established consequences in a cool, matter-of-fact manner. Yeah, I know, it's easier said than done. But never discipline a child with attachment disorder when you are in an emotionally charged state because they enjoy it. They enjoy you being upset because they know that they have control over you. And this makes the child feel more unsafe and may even reinforce the bad behavior since it's clear that it pushes your buttons. Next, you need to be immediately available to reconnect following a conflict. Conflict can be especially disturbing for children with attachment disorders. After a conflict or tantrum where you've had to discipline your child and give them those negative consequences, you need to be ready to reconnect with them as soon as they're ready. This way, you're showing them and reinforcing your consistency and love, and it will help your child develop a trust that you're always going to be there no matter what. Even if you were upset with them, even if they did something that is against your rules, all that, showing up afterwards immediately will teach them they don't have to grovel for your attention. They don't have to try to earn your love. You're there no matter what. So you also need to own up to mistakes and initiate that repair. When you let your frustration or anger get the best of you, and this will happen, no matter how hard you try, there will be times that you will go absolutely ballistic. This happens in normal parenting, but when the behaviors like RAD are completely, exaggerated, yeah, there's going to be times. So if you do something that you realize is insensitive or not appropriately disciplining them, quickly address the mistake. Your willingness to take responsibility and make amends can strengthen that attachment bond. Children with attachment issues need to learn that although you may not be perfect, they will be loved no matter what. And the last one, and God, this is such a big one for me, and I say this in almost every presentation I do, regardless of what it is. You need to try to maintain predictable routines and schedules. A child with an attachment disorder won't instinctively rely on loved ones and may feel threatened by transitions and inconsistency. A familiar routine or schedule can provide comfort during times of change. Predictability is crucial because it takes away the anxiety of what comes next. You must adhere to your schedule to the point that it becomes a natural occurrence every day. And this is good for all kids, even adults too. You'll really be surprised at the power struggles that dissipate by having a strict routine. That's like in my home. We have the exact same routine, Monday through Friday because we have school. I have school-age children. And they know that they're going to wake up, they're going to have breakfast, they're going to get dressed. We do a family meeting, they go to school. When they come home, they have their snack, they play, then they have dinner, and then they have educational iPad time while we do baths and showers. And then after that, we have a quick snack before bed. And then we read stories all together as a family, and then they go to bed and we wake up and do the same thing every morning. Even me saying it, I could say it so quick because it has just always been a part of our lives ever since we had our kids come into our home. They even know what comes next. They always know, and they'll even say, well, it's time for our family meeting or other things. And that's so important just for all kids. Sometimes it can be hard to make a predictable routine. And even when there's a hiccup, you have an appointment or other things come up like a visit or other stuff, You just need to be able to tell them, and this is why we have family meetings in the morning for my family, is that we go over what our day is going to look like and if anything's different. And that gives them the opportunity to predict what happens next, and they're not as afraid. So, beginning the healing and repair. You begin repairing attachment disorders by helping your child feel loved. A child who has not bonded early in life will have hard times accepting love, especially physical expressions of love. But you can help them learn to accept your love with time, consistency, and repetition. Trust and security come from seeing loving actions, hearing reassuring words, and feeling comforted over and over again. So, to heal and repair, you identify actions that feel good to your child. If possible, show your child love through rocking, cuddling, and holding. Attachment experiences they definitely missed out earlier in life. But always be respectful of what feels comfortable and good to your child. In cases of previous abuse, neglect, and trauma, you may have to go very slowly because your child may be very resistant to physical touch. It may take a really long time before they even allow you to touch. Just keep showing up, and with time, the trust will build and the physical affection will come. So with our second oldest daughter, she would not be within, 3 feet roughly of my husband, would not look at him, would not speak with him, would not touch him. She was fine with me, but she's experienced sexual abuse from a male. And because of that, she just wasn't able to connect with my husband. So like I said, it was about 6 months in before she would even touch him. But over time, my husband every single day would just keep showing up with love and affection, but not physical affection, and trying to speak with her. And every night, just reading a story next to her, not touching her, but next to her. And over time, it built that bond. And now she's the biggest daddy's girl in the world. There is a light at the end of the tunnel with some of this stuff, but you just have to keep showing up over and over. So the next one is responding to your child's emotional age. I will point out that one of my biggest pet peeves in this world is when I hear a parent say, act your age. Not everybody's brain matches with the amount of years they've been on this planet. And children with attachment disorders often act like younger children, both socially and emotionally. You may need to treat them as though they were much younger, using more nonverbal methods of soothing and comforting. Just because, for example, a child's physical age is 10 years old, there may be, that she requires parenting of a 4 or 5-year-old. Love them where they're at, and they will develop much more rapidly than if you hold them to a higher expectation, such as you would expect from a child of the same physical age. I will use the example again of my daughter that I was just talking about. She is currently 7. When she first came into our home, she was 4. She, physically, 4-year-old size, all this. However, in her brain, she was around 1.5. That is not a dramatization. That is legitimate. Now at 7, I would say she's around 4.5 to 5 years old. But that large of an improvement came through so much consistency, so much structure, so much routines, and a lot of professional help. So it's extremely possible for them to get closer to their physical age but there might be a chance that it'll never happen. And that's okay. You love them where they're at, and that will be so much better than trying to force them to quote unquote act their age. So, next, you need to help your child identify emotions and express their needs. Children with attachment problems may not know what they're feeling or how to ask for what they need. Name and validate their emotions. Reinforce the idea that all feelings are okay and show them healthy ways to express those emotions. Remember, you do not get to decide if their feelings are true or right. You just help them name the emotions and work through them. So lastly, listen, talk, and play with your child. Carve out times when you're able to give them your full, focused attention in ways that feel comfortable to them. I know it may be hard to drop everything, eliminate distractions, and just live in the moment, but spending quality time together provides a great opportunity for your child to open up to you and feel your focused attention and care. It is all about building that bond and attachment, and by doing this, it begins to form a strong foundation for that to happen. Some people do, mother-child dates, father-child dates that are very specific to children. I know if you have a large group of kids, that's really beneficial to give them that undivided attention. And that includes, putting phones away and just not think about work, not think about anything else that's going on in your life, but really giving them that time, because we as adults want people to respect us enough to give us undivided attention. Kids want that too. So, supporting the health of a child with attachment issues. I'm just going to go over this briefly because I know some people are like, yeah, sleep, eating, exercise. Does it really help that much? It does, but I'll just go over it briefly. Your child's eating, sleep, and exercise habits are always important, but they're even more so for kids with attachment problems. Healthy lifestyle habits can go a long way towards reducing your child's stress levels and leveling out those very frequent mood swings. When children with attachment issues are rested, relaxed, and feeling good, it will be much easier for them to handle those life challenges. Any one of these things, food, rest, and exercise, can make the difference between a good and a bad day for a child who has an attachment disorder. And if it's a good day for them, it's a good day for you. If it's a bad day for them, that's going to be an awful day for you. So really keep that in mind. Know what the doctors and professionals should be doing. I know you may not be a professional in the field. I'm not saying that you need to know everything that they know. What I'm saying is that in order to advocate for these kids, you must know how to make sure they are getting the quality services that they need. So, for young children with a history of foster care, adoption, or institutional background, clinicians should inquire routinely about A, whether the child demonstrates attachment behaviors, and B, whether the child reacts appropriately with strangers. The professionals conducting a diagnostic assessment of RAD should obtain direct evidence from both a history of the child's patterns of attachment behavior with his or her primary caregivers and observations of the child interacting with these caregivers. That, once again, doesn't have to be biological parents or foster parents or adopted parents. It's just whoever the caregivers are. Professionals should perform a comprehensive psychiatric assessment of children with RAD to determine the presence of other disorders the child may be suffering from. This is also good because if they may not necessarily be diagnosed with RAD yet, and so it's really good for them to see if there's anything else, like that autism or the depression, stuff like that would make RAD not the correct diagnosis. The professional should also assess the safety of the current placement for previously maltreated children with negative behaviors who are at a high risk for being re-traumatized. Not every foster home is ideal for a child with reactive attachment disorder. This doesn't mean that they're bad foster parents or bad adoptive parents. There are special homes that can handle and manage these behaviors more easily. Like I said, it doesn't mean that a home's bad. It's just that that's not the ideal placement for them. The most important intervention for young children diagnosed with RAD is ensuring that they are provided with an emotionally available attachment figure. A lot of the times, I've seen that if it's a two-parent household, that one of them stays home. And that works well, especially for children with RAD. I'm not saying that if that's not your situation, I'm not saying that you're in a bad situation, but I'm saying that if you have someone at home with them, it works well so they can be monitored appropriately, but also you're always emotionally available. So next, for young children diagnosed with RAD, limiting contacts with non-caregiving adults may reduce signs of the disorder. So remember, if they meet a stranger, they are more than likely going to act pretty superficially charming, and they're going to behave better for strangers because they can manipulate them. If they're constantly meeting strangers and they're constantly dealing with people they don't know, then they're using their manipulative skills so often that it's not really helping them. You want them to avoid those situations so they understand what true, attachment and bonding is. So I've seen a good routine make a big difference in it. Absolutely. I agree. A good routine, not even just for kids, but for adults too. It's such a good practice to have. And I'm not saying that a good routine needs to be hour by hour, all planned out, but just knowing, an order of events, what's really supposed to happen during your day. And I described my routine earlier, but you notice at schools, they don't just have chaotic days. They have, okay, well, right now is math. They know that next comes reading, and then they go to music and PE. And you typically see less behaviors at school because of those strong routines that they have every single day. So absolutely, good routine definitely makes for having a good day. Professionals should recommend interventions for children who display aggressive and/or oppositional behavior that is pretty common in children with RAD. These interventions truly need to be specialized for your child because what works for one might not work for another. That's common with most children just in general, but especially with RAD. If you give one child who has RAD a certain intervention and it works really well, but then try it with another, it could create your worst nightmare. So it really just depends. Working in conjunction with professionals is so key. I know that personally, I text my case managers and the therapists of my kids and, the OT and psychologist. I'm in constant contact with email and texting, probably to the point that it irritates them. But that way we are all on that same page because it's so important. Medicinal interventions are not indicated for the core features of RAD. So unless there's something else going on, medication is not always necessary. And uh, I know a lot of kids who have RAD who are on medicine. Now, they might be for another disorder that's kind of conjoined with that. Or I've seen a lot of kids, they're taking sleeping medication because they're so stressed out and on edge that in order for them to get an adequate amount of sleep, that they might have to be on sleeping medication. It really just depends on the situation. But for RAD itself, you're not dealing with medicine to help with treatment. It's those therapies and other stuff like that to increase the bonding and the attachment process. So professionals also should not administer interventions designed to enhance attachment that involve physical restraint or coercion. This is like therapeutic holding or compression holding, reworking of trauma, like rebirthing therapy, or promotion of regression for reattachment because they have really no empirical support and they've been associated with serious harm, including death. So, we can't, as foster and adoptive parents, we are not allowed to physically restrain somebody as it is. I know that there are instances like life-threatening situations where that might apply, that you might have to do that. But in general, if you're forcing somebody who definitely doesn't want to touch others, it's not helpful to physically restrain them to make them want to touch other people. It just doesn't make sense, and it truly doesn't work. So like I said, there are some situations that are life-threatening, and when working with children with RAD, there are those moments that they might, make some very poor decisions that result in them having to be restrained, but definitely not to provide any therapeutic interventions. So went through that fast. I tried to get through it as quickly as I could. Like I said, RAD's one of those topics I could talk about it for years and years, but we just don't have the time for that. So on the right, here's my contact information if you want to speak about specific interventions for your child, or if you have any questions, feel free to contact me. Seriously, my goal in life is just to help as many parents as I can, and that includes foster adoptive parents and, especially parents who deal with kids who have RAD, because it's super isolating and I just don't want anyone to ever feel like they're alone. So I also just want to take the time to thank all of you. Thank you for the courage to welcome a stranger into your home with little to no knowledge of who they are or what impact they're going to make. Thank you for being driven by hope and faith that you can make a positive difference in the life of a child. Thank you so much for understanding the damage and the impact of childhood trauma and making every effort to help foster children to heal. And thank you for being one of the most significant lifelong influences in the life of a foster child. I really appreciate you guys hanging in there with me. That's all I have.
Are you there? Hello?
I'm here.
I have a quick question.
Yeah.
So when we're trying to figure out if it's RAD or not, and we're taking them to the professionals, should we be inquiring about a brain x-ray or something like that to start out there, or how do we go about that?
My opinion is if you're going to professionals, you need to make sure you're going to people who are trained with trauma, because not all doctors are the same. Not all doctors understand all the trauma and the impacts it has on the brain. But if you go to someone who specializes in it, they are probably going to have pretty good recommendations on what they believe that they're going to do. When it comes to diagnosing RAD, it's not so much about the brain scans, it's about everything else that goes into it as well. So to answer your question, it really depends on the professional, But if you're going to somebody who's got, you know, experience with trauma, I think they'll lead you in a really good direction. I saw another question. I know you probably said this, but I have a child that I think's listening to you. I feel she needs to be tested. Where and who do I go to? So it depends. Are they in therapy? If they're in therapy, I would talk to that professional. If they're not in therapy, I would try to get them in therapy as soon as possible, or just go to your doctor and say, look, this is what's going on. I really want them to be referred. This is how you advocate for these children. You really show up and you really push until people just, they basically agree with you just to keep you quiet. But I know for my kids, I've had to advocate to the point that I've had to go to multiple doctors. So if they're in therapy, I'd talk a lot with that therapist. If they're a foster kid, I would talk with their case managers about getting them referred to. If they're not in any of that, then I would definitely go to your doctor or pediatrician, depending on the age, whatever it is, and make them, not make them, but suggest strongly that they get a referral to a child psychologist, so that way they can be referred and they can go through what's needed to get them to be tested.
Okay.
It's an eye opener. Thank you for the class. Can we get a copy of your slides? If you go ahead and get a hold of me by phone, or you send an email, go to the website. That way you can connect with me through email, and then I can get you a copy of my slides. I really appreciate you guys all showing up. Like I said, you guys are some of the most important, significant influences in these kids' lives. So thank you so much.
Thank you, Janet, for helping and providing this for us.
No problem. I really appreciated doing it. Thank you for giving me the opportunity.
You guys should all receive a survey that'll have to get filled out and sent back in. Once we get the survey back, we can send out the certificates for the training. And if you have any questions, you are welcome to reach back out to us or Janet.
Yeah, on that survey, we're not able to, do we need to print it off and then scan it back in?
I believe you do. Oh, I think, yes, I want to say last time we had one of these, it comes through your email and you'll have to print it and scan it back in.
Have a good one. All right, thank you so much.